Good morning and good evening. It's my great honor to lead this talk together with our young faculty, Dr. Wendy. She will present after me later on. So the delivery of the service screening for colorectal cancer should be always achieved through opportunity screening and organized mass screening patterns. So the difference between these two types of screening programs mainly rely on how and whether the eligible subjects are invited, the test subjects are referred to have a complementary process, the pre-cancer and the early detected colorectal cancer have periodical surveillance. So we will present the design and the implementation of colorectal cancer screening programs using the Taiwan experience as an example. So before we launch the screening programs, so this is quite important to see the disease burdens before we launch the screening program. So around the 1990s, so we have observed the rising incidence of colorectal cancer in Taiwan. So we face this kind of disease burden. So we try to have a screening to control the colorectal cancers. So this is the evolution of our colorectal cancer screening programs from a high-risk group approach in the beginning and to the mass screening programs in community. So in the beginnings, so this is a first colorectal cancer screening program. We use the high-risk group approach. So the following, we use the multiple items. The majority are related to the family histories to identify the high-risk group and afterlife. So we use the colonoscopy in combination FOBT and DCBE to provide the screenings. And this also demonstrates the evidence to show the effectiveness of mortality reductions by around 30% by using this kind of high-risk group approach, and to support we can deliver the screening to the population. And after that, we initiated a pilot study in northern Taiwan, Keelung cities. So in this program, we try to use FIT as the first line screen modality and to see the feasibility of using FIT in our communities. So we also designed the structure of the screening by following three phases for pre-screening phase, screening phase, and post-screening phase. So in the pre-screening phase, we should have prepare the population data base, including population registry, cancer registry, and mortality registry. And after screening, we should have the screening. We should refer those positive cases to have the complementary examination and also do the evaluation of the programs. So it shows how we do in the community to invite the eligible population to deliver kits in the community and to refer the cases to do the colonoscopy and also the health education after colonoscopy. And this program also demonstrates the high screening rates and also the mortality, the referral rate for colonoscopy to show the feasibility of this screening. So because of the successful and the feasibility of the screening program in Keelung, after that, we launched the the mass organized screening program for colorectal cancer using FIT in whole Taiwan. So, Wendy, please.
Hi, I'm Wendy. It's my honor to share the implementation of mass cancer screening in our country. After a successful pilot study, a nationwide cancer screening service program was launched in 2004 by our government. We offer biannual FIT to the general populace from 50 to 69. And then the upper age limit was increased to 74 in 2013. One of two separate FIT kits, ACAN or QWA, was selected by each municipality according to its own purchase process. The funding of biannual FIT screening is from our annual tobacco tax revenue. Subjects with FIT positive results were referred for colposcopy confirmation. The cost of this confirmatory examination were reimbursed by the National Health Insurance, which has a coverage rate of 99.9% for the entire population. In the inaugural period from 2004 to 2009, the delivery of FIT was based on a community outreach to residents who did not use or underuse medical service, were encouraged to participate in the free screening service of the public health centers. This model derived from KISS. To increase the accessibility of screening starting from 2010, the previous approach was combined with an enriched hospital-based program that invited subjects who were already engaged for treatment unrelated to colorectal cancer in the healthcare system. This model derived from TANKers. This is the screening workflow. Subjects were checked for eligibility and were asked to complete a questionnaire that collected basic demographic data. The whole process of screening activity was under regular monitoring. Subjects tested positive were referred for colposcopy confirmation. If subjects were detected with adenoma by colposcopy, they entered the clinical surveillance. If subjects with a negative colposcopy, according to our latest study, following up this screening and loss can reduce the incidence of colorectal cancer. And we are now considering advising negative colposcopy to undergo a subsequent FIT. And then I will show the performance indicators of mass screening program. We constructed the KPI to monitor the FIT and the colposcopy quality annually. The KPI includes screen rate, positive rate, referral rate, positive predicted value, and the adenoma detection rate of FIT. And the colposcopy quality indicators are assessed by adenoma detection rate and the sickle incubation rate. Furthermore, the screen database was linked to Taiwan Cancer Registry, so later we can find subjects with interval cancer after FIT or colposcopy negative. The screen coverage rate was from 5% to 21% in the first period. In the second period, clinical and the hospital participants in the program, the number of complete FIT increases significantly. In the full program, the coverage screen rate is close to 66%. In 2019, 23% of subjects were screened for the first time, and 77% of the subjects had been screened in the past 50 years. The positive rate of men has been significantly higher than that of women. In general, the positive rate increased from 2006, and then showed a downward trend after 2014. Now the positive rate is 6.7%. Recently, colorectal cancer and the advanced adenoma detection rate for FIT had a stable performance. Out of every 1,000 FIT, about 2 are diagnosed with colorectal cancer, and 6 are diagnosed with advanced adenoma. However, the adenoma detection rate has increased year by year. Adenoma detection rate and sickle intubation rate are the key indicator of colonoscopy quality. It reveals that both ADR and CIR improved substantially from the first period to the third period. ADR reached the standard value of 14 in 2010 and rose to 52 in 2019. In addition, CIR reached 19% of standard value in 2010, and now CIR has reached 97%. We evaluate the quality of screening programs through incidence rate of FIT interval cancer and post-colonoscopy colorectal cancer. This slide shows that the incidence of FIT interval cancer and the CRC have recently decreased over time. Now, out of every 1,000 FIT negative, 0.6 are diagnosed with colorectal cancer within 2 years. And out of every 1,000 colonoscopy negative, 1.4 are diagnosed with colorectal cancer within 3 years. The large-scale population-based biannual FIT screening combined with colonoscopy quality demonstrates 34 significant reduction of advanced stage colorectal cancer and the 14 reductions of deaths from colorectal cancer. Our findings provide a strong and consistent evidence-based policy for supporting a population FIT organized service screening worldwide. There are some challenges that we needed to encounter. First, insufficient manpower, including healthcare workers, medical professionals, and colonoscopists. Second, we needed to work on how to improve screening rate and the repeat screen rate. Next, we needed to solve the problem of insufficient FIT sensitivity and the colonoscopy quality issue, leading to interval cancer with FIT or colonoscopy negative results. Thank you.